any individual who is exposed person with active disease. Close contact. What is close contact? A person who is not in the household but shares an enclosed space such as a social gathering, workplace or facility for extended periods during the day. That's why we have at regular intervals we have tuberculosis screening for our mess workers because they all are our close contacts. Then we have household contacts. A household contact is a person who has shared the same enclosed living space for one or more nights or for frequent or extended times of period during the 3 months before starting the treatment or after starting the treatment. So these people are to be evaluated for any of the respiratory symptoms or extrapulmonary tuberculosis symptoms and diagnosed and treated accordingly. So this is a diagnostic algorithm. It is taken from the latest NTEP guidelines. So first of all, we have a presumptive tuberculosis patient. While we classify it as a normal patient, healthy patient, or like a immunocompromised patient, like HIV, which is very prevalent in India, especially in Dhaka region, it is also very prevalent. So HIV people, they are definitely at very high risk. So first of all, directly we get the CBNAT testing done, which is the fastest testing we have available for our tuberculosis. And if the patient is positive, the very highest of tuberculosis. So for a normal person, if the patient either comes in smear examination, microbiologically patient can come positive either in AFB, smear examination, or by CBNAT or nucleic acid amplification testing. Then we will label the person as a microbiologically confirmed tuberculosis case. Or we can have new cases in the chest suggesting of tuberculosis. We have high suspicion. Even if the patient is not microbiologically confirmed, we will start immediately if the clinically the patient has presumptive TB symptoms, fever, cough, maybe he is a contact, then we can start anti-tuberculosis treatment. And there is a one phenomenon called the universal drug sensitivity testing. Because nowadays in India, the prevalence of resistant tuberculosis is so common that for every person, it is recommended that you should have the drug sensitivity testing and the CBNAT because it tests for the rifampicin resistance. So accordingly, the patients of drug resistant TB can be easily and accurately and early detection can be done and then they can be treated accurately. As I've told you, drug-sensitive TB is the patient's bacilli are susceptible to all four first-line anti-TB drugs. And then we have multi-drug resistant TB, TB caused by MTB strains that are resistant to both isoniazid and rifampicin or without resistance to other first-line anti-tubercular drugs. Then we have RRTB or the only rifampicin resistant TB and the isoniazid resistant TB or the HRTB. Polyresistant TB that may be resistant to more than one first-line anti-tubercular drugs other than isoniazid and rifampicin, like pyrazinamide and thimerosal. Pre-sensitive drug-resistant TB, TB caused by MTB strains that fulfill the definition of RRTB and are also resistant to fluoroquinolones. Pre-XDR we call them. And then we have XDR patients which are resistant to fluoroquinolones and additional group A drugs. In the classification of anti-tubercular drugs, we have A, B, C for resistant tuberculosis drugs. And if we are even resistant to fluoroquinolones and additional group A drugs, or linezolid, both, then we label those patients as extensive drug-resistant tuberculosis patients. Pre-treatment evaluation. First of all, the patient, when he presents to our OPD, we look for the history, clinical examination, any other associated respiratory symptoms, constitutional symptoms the patient is having. Then we have the routinely in all the TB clinics, we have the HIV and the random blood sugar testing because diabetes is also a predisposing factor for tuberculosis infection, and HIV and any immunocompromised state is also a very big predisposing factor for tuberculosis infection. And definitely for if the patient is presenting with symptoms and we get an X-ray done to see the damage on or the infection if the patient has any. Then we jump to the chemotherapy of tuberculosis. So first of all, what is the goal of chemotherapy? We have to treat the patient and we also have to ensure that the people living around the patient are not getting infected because it is a highly infectious disease. I told you it spreads from droplet infection. So we have to even make sure the patient is non-infected for the other community as well. And we have to reduce the mortality also because it is very fatal if the patient is left untreated, even for the patient and the surrounding people also, because elderly, children, and the susceptible population. So we have different TB regimes. So commonly that we follow is a 6-month regime for drug-sensitive tuberculosis. As you all know, HRZE and HRZE for 2 months intensive phase and 4 HRE. So this is the intensive phase, HRZE, the red, because people mostly in India they're illiterate. So how do they differentiate the VR intensive phase or continuation phase? So our government has made a provision. The intensive phase tablets they have in red color and the continuation phase tablets they have in green color. They are given by weight. It's a fixed dose combination so that the patient is not confused about taking multiple tablets during the day according to the weight. According to the weight band, the best suited weight band, then the patient is given a fixed dose combination, 2 tablets, 3 tablets, whatever suits him. So this is the mechanism of action of the antitubercular drugs. I think you all must have read it better in pharmacology. So we have this what drugs have what bactericidal or bacteriostatic activity, and this is the treatment regime, intensive phase, and this is the continuation phase. This is the weight band for antitubercular therapy. During the treatment, we have to continuously ascertain the weight also of the patient. If the patient has increased his weight, then we have to shift the weight band also, or else the ATT would not be effective on that patient. So this is the dose per weight wise. In some patients in which we are not able to give the MBC, then we have to give these doses of the individual drugs weight wise. So there are special cases that has to be discussed when you are in OPD. If the patient is pregnant or a lactating mother comes and she is positive for tuberculosis, because tuberculosis is very highly biodroplet to the baby also. So first of all the ATT drugs, the first line ATT drugs, HRZD, they are safe in pregnancy, except for streptomycin, which is not a first line drug at present, but it has antitubercular activity. But so we can give HRZD easily in pregnant patients. Even for breastfeeding babies, we give ATT. We advise one thing that we tell them the cup hygiene. The breastfeeding mothers, we tell them they have to be very cautious while they are breastfeeding their baby. They are not supposed to cup or even generate any droplets so that a small baby gets infected. And moreover, we tell them to take some gap just after breastfeeding that she can take ATT. So there is risk of minimum secretion of the ATT drugs in the breast. But we encourage them to give the child breast milk because the breast milk has a lot of immunomodulatory and antibacterial properties as well. And if the small child shows some symptoms or the patient is not maintaining up hygiene or it is suspected that the child might be infected, so we give 6 months of isolated therapy to the newborn baby also. And TB and contraceptive pills in young women, and we have to be very cautious about giving antitubercular drugs and contraceptive pills because enzyme inhibition and all, the efficacy of the contraceptive pills goes down. So we have to be very cautious and tell the patients to escalate their contraceptives or to use alternative methods of contraceptives while they are on ATT. So alternative methods that they can use are barrier methods, IUDs, or medroxyprogesterones, implants, hormonal implants. So we have a lot of patients that present with liver disorders and they are on ATT. And second type of patients, because most of the drugs in ATT they are very hepatotoxic. So they can have a very deleterious effect on the liver. So how we manage those patients? First of all, we have to look for the signs and symptoms. If they are presenting with any nausea or they are having any complaint, any position they are having fatty liver or they are chronic alcoholics, that has to be ruled out. And then serial monitoring of the liver function test has to be done. Ultrasounds has to be done. And then accordingly, we can modify the ATT. There are a lot of hepatoprotective regimes, that is isoniazid, rifampicin, streptomycin and ethambutol, followed by 7 months of HNR, isoniazid and rifampicin. You can give 6 to 9 months of rifampicin, pyrazinamide, and ethambutol, or 2 months of isoniazid, ethambutol, streptomycin, or any fluoroquinolone for 10 months, or isoniazid and ethambutol. And there is some regime for containing no hepatotoxic drugs, but it is a longer regime, 18 to 24 months, very common CKD patients presenting with tuberculosis. So first of all, stay up to stage 3 if the EGFR is more than 30. There is no problem with giving the ATT drugs. But then you have to also monitor the patient serially. If it is not deteriorating, the CKD is not deteriorating. For patients in stages 4 and 5 chronic disease, and especially the patients with hemoparalysis, should be increased to 3 times weekly for ethambutol, pyrazinamide, and aminoglycosides. Treatment can be given immediately after dialysis to avoid premature drug removal, because once you do hemolysis, all the drugs are mostly filtered out. With this strategy, there is a possible risk of raised drug levels of ethambutol and pyrazinamide between dialysis sessions. So you have to do continuous monitoring for those patients, for CKD and for ATT side effects as well. First of all, abdominal pain, nausea, burning of feet, these are common side effects. We supplement the patient with pyridoxine, and we give them Pantoc DSRs and other things to control the GRD, and we reassure the patient. And then if the patient comes with GI upset, drowsiness, especially it is related to isoniazid, we reassure the patient first of all, explain them it is a common side effect of the drugs, and then we give them proper antiemetic drugs and tell them to take the drugs for a prolonged period of time. Like if we are telling the patient to take 4 tablets in a span of 30 minutes, then we tell the patient to stretch the span to 2 hours, 1 hour, and things commonly related to pyrazinamide. We continue pyrazinamide, give symptomatic management, NSAIDs, and we observe the patient. If it is not rising to alarming levels, then we can give another treatments for lowering down the uric acid levels as well. Red urine on women on rifampicin, it is a common misconception that the urine has become bloody after taking ATD. So it is a common side effect, as I told you. So if the patient has to be counseled about that as well, because psychological management is also very important. You have to treat the psychology of the patient, physiology of the patient, and you also have to treat the patient's vicinity also, the people surrounding the patient. Now we also have a concept called the TB preventive therapy. So it consists of a course of anti-tubercular treatment. Its primary intent is preventing the development of tuberculosis disease, given to a person who are exposed to TB and are at a higher risk of developing tuberculosis. So what we have, what are the indications of TB preventive therapy? Target population, especially people with HIV, adults or children who are more than 12 months, because till 12 months we have maternal protective immunity. And infants less than 12 months in contact with active TB. Or below 5 years of pulmonary TB patients we can also give. So in these patients we prefer 6 months of isoniazid therapy or 3 months of weekly isoniazid and rifampicin in persons older than 2 years. Commonly it's a 6 months isoniazid therapy is given in our TB centers. And the other groups include the children, adults on immunosuppressive therapies, patients with silicosis. Patients with silicosis have a very high risk of harboring TB bacteria, so they have to be treated. Patients on anti-TNF treatment, organ transplant patients, patients on dialysis, patients on transplants, cancer patients. We give 3 months weekly isoniazid and rifampicin or 6 months of daily isoniazid. 6 months of daily isoniazid is commonly given in the TB centers. For drug-resistant tuberculosis. As I already told you the definition of drug-resistant tuberculosis, isoniazid drug-resistant tuberculosis, rifampicin resistance. Commonly that we encounter is a rifampicin resistant tuberculosis, and then we can have the multiple drug-resistant tuberculosis, extensively pre-XDR and XDR. So what are the groups ABC? And this is a very important question for your exams as well. Group A consists of levoflox, moxiflox, the fluoroquinolones, bedaquiline, and linezolid. And group B consists of clofazimine, cycloserine. Group C consists of ethambutol, delamanid, pyrazinamide, meropenem, PAS, and ethionamide. Newer anti-tubercular drugs, that is bedaquiline. Bedaquiline is a newer drug that has been approved. So we have it in 100 mg tablets. It is provided free of cost by the government of India. highly expensive tablet imported from Japan. Then we have predetermined mechanism of action. Inhibits the cell wall synthesis by disrupting the mycolic acid synthesis pathway. It is available in 200 mg tablet. Then we have Delamanid, 50 mg tablet we have. It also acts by inhibiting the mycolic acid synthesis. So this is the evolution in the treatment of drug-resistant tuberculosis. Currently, we are practicing the BPAL regimen. This is the shortest regimen for drug-resistant tuberculosis available. Earlier, we were giving the 9 months shorter, extendable up to 11 months, and giving the 18 months, 12 months longer, extendable up to 18 to 20 months. So this is the algorithm. First of all, we will check the patient for resistance, and if the patient comes resistance, then there are criteria which patient can be taken up for longer, all oral longer treatment or shorter treatment. Shorter treatment is mostly obsolete now. Either we go for the BPALM, the fresh cases more than 14 years of age, they have to be started with BPALM because it is a shorter, less side effects, and reported less drug resistance in further drugs. And then we have those people who don't qualify for the BPAL regimen, then we go for the all oral long regimen. And the treatment duration may vary on the drug sensitivity testing and the culture reports that subsequently come when the patient comes for follow-up. So, as I told you, the different regimens for DRTB. This is the shorter oral bedaquiline containing regimen. These are the indications. The total duration is from 9 to 11 months. It consists of an initial phase of 4 months that can be extensible up to 6 months and a continuation phase of 5 months. Total duration of 9 to 11 months. Bedaquiline is used for a duration of 6 months because it is highly cardiotoxic. This is a regimen. In intensive phase 4 to 6 months, we give bedaquiline, levoflox, clofazimine, pyrazinamide, ethambutol, high dose of isoniazid and ethionamide. This has to be given according to the weight band. Weight band prescribed by the NTP guidelines. And this is the summary: 9 to 11 months, IP phase for 4 months, extensible up to 6 months, continuation phase for 5 months. Bedaquiline for 6 months and then it stops. There is a one common clinical point that has to be noted. Non-lactating, non-pregnant or pregnant women with less than 24 weeks gestation who is willing for medical termination of pregnancy, then only we can use ethionamide because it is highly fetotoxic. That's why, or else the ethionamide has to be replaced by linezolid if we want to give all oral shorter regimen to any pregnant female and if she is not willing for MTP. Less than 24 weeks, we advise them and we strictly counsel them to go for MTP because of the risk to the mother and the child as well. More than 24 weeks, the MTP is not permissible, then we have to replace the drugs. This is the BPAL regime which was implemented in 6 September 2024. The primary aim was to reduce the pain burden of the patient and the duration of treatment of the patient. So, what are the indications of the BPAL regimen? It must be the first choice of treatment in all the patients who are eligible for 14 years of age with MDR, RRTB, regardless of the fluoroquinolone resistance or HIV status. What is the inclusion criteria? Age more than 14 years, new microvascularly confirmed MDR TB, probable MDR who failed the H mono or poly drug resistant tuberculosis regime. Inclusion criteria based on drug exposure. Person with exposure of less than 1 month intake of bedaquiline, linezolid and predetermined in the past. Fluoroquinolones is not included in the exposure. Person with exposure of more than 1 month intake of bedaquiline, linezolid or predetermined and documented sensitivity of drugs. Even if the patient has taken these drugs in the past, in the drug sensitivity testing, it's showing that he is sensitive to these drugs, we can start this regimen. People who had not failed the treatment with bedaquiline or linezolid, which was given earlier, although it is presumed that they are sensitive to the drugs. And the inclusion criteria: lactating women but not breastfeeding, non-pregnant or pregnant women with less than 24 weeks gestation who are willing for MTP. BPAL is not recommended for pregnant and breastfeeding women. This is a very important clinical point that we have to note here. What are the exclusion criteria? We cannot give it to small children less than 14 years because we have two cardiotoxic drugs, bedaquiline and ritomavir. We have. And if any of the people have documented resistance to bedaquiline, linezolid or ritomavir, people have significant like this cord spine, they have some MDR TB or extensive TB. If we have, we cannot start with DIPA regimen. People with significant cardiac conduction abnormalities, as I told you, that we have bedaquiline and which are very cardiotoxic. Even before starting them, we have to get a cardiac evaluation done of the patient and make sure that the patient has a significant QT interval so that these drugs do not cause any cardiotoxicity. So this is the regimen. Bedaquiline, weeks 1 to 2, 400 mg daily. Weeks 3 to 26, extensive up to 39, 200 mg 3 times a week. Ritomavir, week 1 to 26, 200 mg daily. Linezolid, week 1 to 26, 600 mg daily. Roxiflox, weeks 1 to 26, 400 mg daily. For pyridoxine, because we know these drugs have a very significant side effect of having peripheral neuropathy. So if the weight band is between 16 to 19 kg, we give them 50 mg of pyridoxine. Or if the weight is more than 30 kg, then we give 100 mg of pyridoxine. Moreover, because linezolid is very notorious for causing peripheral neuropathy, so time to time we have to evaluate the patient, and we also have to pitch in with neurologists and see if the nerve conduction is working and if the patient has significant distress with the drug, we can also lower down the dose of the drug to 300, but the regimen will be extended from 26 weeks to 39 weeks. For having adequate psychological support to the patients, the government of India has also given an incentive of 500 rupees per month for every registered tuberculosis patient directly coming to their bank accounts for drug sensitive tuberculosis. And in case of providers are also incentive, they have given incentives. 1,000 rupees at the completion of the treatment when the tuberculosis patient has completed treatment. The person who presented or got the patient registered will get 1,000 rupees. And drug resistant cases, 2,000 rupees at the completion of intensive phase and 3,000 at the completion of treatment. So, as in the starting, Dr. Shashank told you, the global sustainable guidelines have told that they will end tuberculosis by 2030, but our Prime Minister has told that India will lead this campaign and we will end TB by 2025. Unfortunately, India 26, but still we are working towards that. So, this is the 100 days TB elimination campaign, TB of Bharat Abhiyan. You must have seen posters everywhere. So, it was launched on the 7th December 2024. It was basically aiming at the high burden tuberculosis areas, and we are also conducting regular screening camps and distributing portion copies to all the tuberculosis patients we have which have high burden areas. Thank you. If any of you have any doubts or you have not understood anything, you can ask me. Being a clinician, you cannot escape treatment of tuberculosis. Maybe you take any branch, you have to treat tuberculosis. So if you have any doubts, you can ask me. It can also come as a long question in your examination also, as well as in your entrance exams. In MCQ it comes.